Thank you.
Thank you for coming, oh my friend. I'm so happy we can gather again before the championship game of the 2026 World Cup football. Yeah. Good morning and good evening, every friend. I'm Dr. P.Y. Cho. Today, I will moderate this the
Hello,
132
the password so far
webinar
is at
with
ICC
my
122. Password
co-moderator,
is password.
Junior together. Today is my absolutely privilege and honor to introduce our distinguished guest speaker, Professor Usama Hamdan. Professor Hamdan is an eminent otolaryngologist and a facial plastic surgeon who served as the president and the co-founder of the Global Smile Foundation. For the past 38 years, he has dedicated his career to global humanitarian outreach, providing comprehensive pro bono clip care to underserved patients worldwide. His rich academic background include a former faculty appointment at Harvard Medical School, Tufts University School of Medicine, and the Boston University School of Medicine. As a deeply respected international lecturer, Dr. Hamdan is also the founder of the International Comprehensive Clip Care Workshop, driven by his specialized interest in simulation-based clip training, quality assurance, and long-term sustainability initiatives. His profound global impact has been recognized with numerous prestigious awards, including knighthood from the President of Ecuador and honorary professorship from Espiritu Santo, and the recently humanitarian honors from the El Salvador too. So today, Professor Hamdan will share the topic, the single stage posterior Vomerine ostectomy bilateral GPP, and the Hamdan-VSR technique for first-grade BCL repair in patients with protuberant premaxilla. By the way, always we have our friend and the famous expertise professors to come join as our panelists. The first one, I would like to introduce Professor Phong Nguyen. Professor Phong Nguyen dedicated himself in the Vietnamese club mission annually and based on the Nui Reconstructive International. Let's welcome Professor Nguyen. Hello. And our second friend is the Professor Renato Freitas. Professor Renato Freitas is so famous the professor in Brazil and based on the University Federal do Paraná. Yeah, so I learned quite a lot from Professor Renato from ICC webinar too. Hello, Professor Renato.
Thank
And
you. Thank you.
and the third one is our good friend, Dr. Bernard Tensipak. Dr. Bernard is quite very, very performed lots of like mission care in the local Philippines and established a branch of a Nodal Clare Foundation in the Philippines. Even though his base is in Philippine General Hospital, he served himself locally quite often to give all his support for those patients who in need. Hello, Bernie.
Hi,
So
good evening.
can't wait to learn from Professor Hamdan. So let's welcome Professor Hamdan.
Thank you, PY, for the kind intro, and thank you also for the kind invitation. May I share my screen?
Yes, please.
Let me know if you're able to. I'm going to actually stop sharing and I'll share the regular screen. Okay, and can you see the screen on a, should be coming up.
We can see the screen, but it's not in. Oh, there we go. It's in full screen now.
Looks good. All right. So again, our talk today about single stage posterior Vomerine ostectomy, premaxillary setback, bilateral GPP, the VSR technique for bilateral cleft lip repair in patients with protuberant premaxilla. I have no financial disclosure. And by the way, please let me know if I'm going on too fast. I can slow it down as well. Before we talk about techniques, innovations, or outcomes, we need to ground ourselves in principle that applies everywhere, regardless of setting or experience level. First and foremost, know your limits and do no harm. In complex reconstructive and global surgery, especially in cleft and craniofacial care, the margin for error is small and the consequences are lifelong. Excellence is not defined by how much we can operate, by how wisely we choose our interventions. For trainees, restraint is a skill. For experienced surgeons, humility remains essential. Everything we will discuss today builds on this responsibility to act in the patient's best interest, not our own ambition. This is the outline for our talk today. It's a pretty long one, and I'm gonna try to summarize it as much as I can and to stay within the time frame that we're allowed. First, actually, are the challenges. Patients who present in with protuberant premaxilla, we're seeing more and more of these in outreach setting. They're delayed for PSIO. The financial and psychosocial strain is quite significant for the family and eventually for the patients. They're completely stigmatized and they have very limited access to timely interdisciplinary care. Stage repair basically has its risks and challenges. They require multiple procedures, loss to follow-up, psychosocial impact while waiting for final repair, so on and so forth. And prior techniques have showed unsatisfactory outcomes, unfortunately, for many of these patients. Single-stage posterior Vomerine ostectomy remained underexplored until recently. The problem basically is when the reconstruction falls short, what are the consequences of suboptimal surgical management? And I'm sure many of our colleagues today will be able to share their expertise as well. This is a patient who came in with a protuberant premaxilla. Unfortunately, the surgeon did not know their limits, ended up with severe breakdown and infection and complete loss of the prolabial flap. And results over and over again, another patient whom our team was taking care of in Ecuador, and we're doing pre-surgical orthopedics. Somebody called the mother and told her there's another gringo group coming in, come over, and this is the outcome as well. A third patient as well who underwent unsatisfactory repair with the premaxilla protruding through her left nostril. Another really heartbreaking patient, basically 3 surgeries done within 1 month, and the wound kept opening up. The problem is that the surgeon did not also realize basically what the limitations are. These are the secondary palatine shelf. This is the size of the premaxilla. She's trying to repair the lip in front of this projected premaxilla that was not gonna go anywhere. And even if this stayed basically closed, the premaxilla was locked in place because you were not able to expand the shelves and allow it to set back. Mistake upon mistake upon mistake. And unfortunately, this is what the problem is, what the patient, what the time we saw her several months later. The worst situation is when the surgeon tries to close the lip and they can't, and they end up chopping off the premaxilla with a pair of scissors just to give them the comfort that they can close the lip, thus devoting the patient for a lifetime. There are some existing techniques right now. Bilateral lip adhesion continues to be used worldwide. The problem is, again, like what we see with this patient, many fail to come back for follow-up. They don't have the muscle decussating across, so the lip is not functional, and the patient is left with a significant deformity that interferes with their functionality as a student, as an employee, and whatsoever. Many a time, basically, the lip breaks down, and then the surgeon goes back to try to attach the lip again and again, causing more and more necrosis and more loss of the prolabial flap. Raj Vyas and our late John Mulliken reported a paper on anterior ostectomy, anterior to the VPS, and unfortunately, 20 to 30% of the premaxilla was lost in the process, and it limited the amount of the rhinoplasty that could be done because it was also interfering with the blood supply as well. So the posterior vomerine ostectomy for the protuberant premaxilla basically has really worked very well in our hands. Again, as a disclaimer, this is not a technique to go for when PSIO is available in developed countries or in countries that are able to provide pre-surgical orthopedics. However, the Vomerine ostectomy and the setback is very effective treatment option when these things are not available, especially in low resource setting, be it in Kentucky here in our country in the US, or being anywhere else in the world where the limitations are quite constrained, basically. The blood supplies, as described by our dear friend Percy Russell Perry, the dorsal nasal artery provides the blood supply for the premaxilla. This is why the vomerine ostectomy anterior to the VBS resulted in so much necrosis as compared to our technique doing the ostectomy posterior to the VPS. This is the vomer bone, and this is a 3D CAT scan rendering. This is the premaxilla, and this is the VPS area, and this is how much of an extension you can see these patients coming in. This is actually one of our patients, and I'll be sharing their post-op result at the end of this lecture. So the technique basically is 5-in-1. Is posterior vomerine ostectomy, premaxillary setback, bilateral GPP, bilateral cleft lip repair, and primary cleft lip rhinoplasty. It is, we call this a conjoint double Y incision, whereby the anterior margin is 5 millimeter posterior to the VPS to ensure the structural integrity of the PPS and the blood supply to this area. It really allows the premaxilla to set back into a nice place and to marry the secondary palatine shelves. And this is a video that will show the technique. The combination of lidocaine and marcaine with epinephrine is injected, and I'll be more than happy to share the multiple articles and chapters we produced. This is the vomerine ostectomy based on the size and the extension of how much the premaxilla is protruded anteriorly. You can see that the septum is preserved and how it is angling basically with the pressure on the posterior on the premaxilla as well. Then the premaxilla is held in place through bilateral GPP and 8-point fixation system. The 8-point fixation system has really helped us maintain the stability of the premaxilla with limited to no movement at all in our long-term patient follow-up as well. These are the 4 palatine sutures that are applied. Usually we use 4 ovicural on a tapered RB1 needle. The assistant holds the premaxilla in place while the sutures are tied, and then the buccal side of the sutures are then applied, also 2 on each side, resulting in a total of 8 sutures. And this is illustration from the book that we published 3 years ago with the amazing illustration from David Lowe. We're exposing the periosteum over here, and then the sutures are applied on the palatal side first and then on the buccal side. And this is the premaxilla, and the premaxilla held in place. And this is a 2-year follow-up, and you can see how nicely the premaxilla is aligned with the secondary palatine shelf. There are 3 types of projected premaxilla. One, whereby the secondary palatine shelf is inaccessible, and there is complete collapse and interfering with access to the vomer bone. A straight one and a curvilinear or skewed one. With the straight one, it is you just measure the distance of the projection, You go 5 millimeter behind the VPS and you decide how much bone to take and push it back and do the 8-point fixation system. With the skewed one, you have to angulate your ostectomy basically based on the angulation so that you can end up with a straight line, as in this patient here, with perfect alignment with the secondary palatine shelf. And the aim is minimizing the pressure on the repair of the bilateral lip, allowing to do all this 5-in-1 procedure in one setting and not having to bring the patient back multiple times to have an outcome. They're able to integrate into the society. It allows you to do nicely the rhinoplasty component as well, that we will discuss in detail. The other challenge basically that has been is the short prolabial flap. You have this prolabial flap, no matter how much you lengthen it, if you're using the vermilion border flap techniques, basically, there's a significant distance difference, basically. So what the surgeons end up in, they stick a stitch from the tip of the prolabial flap where the low point should be, and they bring it down. And what does this produce is it pushes up the nice curvy linear Cupid's bow superiorly, and then it's positioning it in a much abnormal position than what cosmetically is should be expected. As a result, as you can see, complete obliteration of the Cupid's bow, along with the blunting of the infratip lobule. Patient upon patient that you see with this kind of blunting of these things, because they have not done what we have found to really produce a very nice outcome in our patients. So you do a relaxing incision on the lateral aspect of the C-flap and you extend it all the way into the membranous septum. That frees up, because you've done the ostectomy posterior to the VPS, you know that the blood supply from the dorsal nasal artery is intact over here. As a result, you're okay in extending this incision into the membranous septum, and this allows actually the prolabial flap to extend inferiorly. This is the front cover of the new edition of the special issue on anasoplastic surgery that's coming out next week on Cleft Pit, that Jordan Swanson, myself, and Matthew Pontel were the editors in. So basically, it shows basically the V-chyloplasty technique, the step-down technique, and the rhinoplasty, and we will go this in detail. This is the front cover, actually, of this special issue. The surgical marking for this technique is contrary to doing the matching 2 millimeter by 2 millimeter. We do a 2 millimeter on the prolabial flap with a corresponding 3.5 millimeter here curvilinear to allow the filtral ridges to heal in a straight line. But we increase the size to 3 millimeter on the vermilion border flap to maintain the V structural integrity of the Cupid's bow. Next is you do the incisions and you do an inverted V shape with the frenulum in to be able to reconstruct your frenulum. You raise the flaps over here. This is a nice anatomical illustration by our illustrator, showing the abnormal insertion of the muscle into the alar base. You do a rhinoplasty, which is a cartilage sparing technique through a transculamellar approach, and my technique for the alar base flap incision that was described in 2006. This is on the upper edge of the vibrissae, and it stays 2 millimeter posterior to the lateral border of the posterior crus, which allows you to mobilize the alar lobules medially with keeping the structural integrity of the lower lateral cartilage. Then the orbicularis oris muscle is separated from the abnormal insertion into the alar lobule, is done in a retrograde fashion, and you stop at the vermilion border. Next is you recreate the frenulum by borrowing additional tissue from the buccal flap from lateral to medial, and this really avoids the blunting of the gingivo-buccal sulcus as had been seen by other techniques as well. A triangular suture is applied, and as you can see, the arrow by bringing the buccal mucosal flaps from lateral to medial, and the triangular suture creates a nice frenulum as a midline point. And then the V-caloplasty technique is based on a lot of arithmetic and geometry. What it does basically is the upper sutures are taken much wider than the lower sutures, and it comes down in a downgrained manner as a V shape. This allows the alar base lobules to move medially, and they minimize the lateralizing vectors of healing. And the pars peripheralis, and 2 sutures are applied in the pars marginalis. Then you need to go in and put multiple sutures throughout the whole circumference of the muscle, because these 5 sutures alone are not enough to give you this nice continuity of the muscle. Next is the rhinoplasty technique, whereby we do the alar base flap suspending suture that was described in 2006. This allows the alar base flap along with the V-caloplasty to be mobilized more medially. And this is the stitch, as you can see over here, which gets tightened at the end of the surgery once you ensure the symmetry of the nostril. Next are the double dome sutures that are done without exposing the lower lateral cartilage. The Q-tips allow you to tighten the stitch as well for a nice symmetry of the nasal dome. This is followed by alar crease transfixion sutures to kill the dead space. If you don't do that, a lot of scar tissue will build up here, and the abnormality is very difficult to correct because of the extensive scar tissue in the area. Next is the soft triangle suspending suture that takes care of the redundancy in the soft triangle without having to do the Tajima incision as well. As you can see here, this is redundant. You put in the soft triangle suspending suture, and that corrects the redundancy in that area. In adults, where you cannot use a long PS2 needle, use a straight 3-0 monocle on a straight Keith needle to give you that suspension as well. Once a transverse crural transfixion suture is then applied, and the fact that you've done this relaxing incision into the membranous septum allow the prolabial flap to be able to move down. We do then asymmetrical suturings from the prolabial flap to the lateral skin flaps by bringing them down, and this really fills in this gap. By the first stitch, as the video will show, that covers 50% of the gap. The second stitch stretches the prolabial flap by the addition 50%. So this lower part of the prolabial flap is sitting and kissing the newly reconstructed vermilion border, the cupid's bow, without any tension and without any superior dislocation. And again, this is thanks to the releasing incision in the membranous septum. And this video basically will show you the technique. Asymmetrical sutures from the columellar labial angle. It goes down several millimeters on the lateral advancement flap. And then the comparable sutures is put on the opposite side. And notice how the prolabial flap starts going down. Next, the second suture, the same thing. And by the second suture that's applied, you'll notice that the prolabial flap is almost setting in nice continuity with the cupid's bow. And then you fill in the muscle deficiency with interrupted bilateral sutures to ensure the continuity of the muscle and the nice homogeneous shape of the vermilion border. And this is how the prolabial flap has been brought down through the step-down technique. And again, this is the cover for the special issue, and that shows the dynamics basically behind this technique. This is a patient 4-year post-op, and you can see a nice columellar length and a nice projection of the nasal tip without any blunting in that area, and symmetry of the nostrils all around, and lengthening of the columella as well, as compared to those patients who don't get this releasing incision, short columella, blunted infratip lobule, and significantly asymmetrical nostrils as well. The patients, when they come back, all our patients who undergo the setback we document the bone repopulation when we're doing their cleft palate. And this is when the patient undergoing a cleft palate surgery. And you can see over here the continuity of the vomer bone. And we've been very happy actually to see this kind of documentation around another patient 1 year post-op with a nice homogeneous continuity of the vomer bone and a nice alignment of the palatine shelves as well. The issue was when we started doing this procedure, what happened to facial growth. So we started a prospective study of our own patients, and the first paper basically was published in CPCJ several months ago, showing basically that there is no significant difference between our sample mean age, race, and sex matched patient group as compared to our controls that were born in the same racial group and born with no cleft. And the facial growth parameters were the same, 16 out of 22 parameters for 22 patients. This was a pilot study. The second study that now we're working on, we just submitted for publication, included a total of 42, also concurred with the same finding as compared to the controlled group with patient born with no cleft. There is no difference in the facial growth between these two groups. We're working on a third paper right now as a multi-center study. And by the time we're done with this one, we'll have close to between 80 to 100 patients to hopefully confirm these outcomes. All the cephalometrics and the analysis is done by Dr. Puneet Batra as an independent reviewer as well to ensure the integrity of this analysis. So from routine to challenging reconstruction. This is a patient immediately post-op, one day post-op, and you can see how this technique has been allowed you to reconstruct the lip and the nose, the columella, as well as do the premaxillary setback with a nice projection of the infratip lobule and the columella. Ethan actually is a premature baby, malnourished. We had to bring up his nutrition over a 6-month period with a special feeding bottle and our team in Ecuador. And this is him after having fully regained his proper weight and with a one month follow-up as well with nice satisfying results. Ugo with a 1 year follow-up as well, 1.5 years from South Africa. The surgeon in South Africa, when she started operating on the patient, she realized that this is significantly projected premaxilla, ended up doing a lip adhesion on one side, and luckily it allowed us to do the whole premaxillary setback and the lip reconstruction without really much damage to the prolabial flap. And this is Ansel, 1.5 years later, is growing very nicely. 8-month follow-up. And again, all these outcomes show nice alignment of the premaxilla with the secondary palatine shelf, nice nasal symmetry, and lip growth as well. 3-year follow-up of another patient with a severely protuberant premaxilla, 4-year follow-up, another 4-year follow-up with a nice alignment. And we continue to see these patients year after year. And very happy basically with the way the facial structures are growing with minimal to no impairment actually on the symmetry of the nose. This is a 5-year and a nice continuity of the muscle and nice alignment of the jaw as well. 4.5-year follow-up. And this is one of our 7-year follow-up patients as well. Oliver came to us in 2021 during the COVID era, basically severely protuberant premaxilla, and unfortunately the case was canceled because of COVID and he was sick. This was 3.5 centimeter projection anteriorly that was removed, and this is the conjoined double Y incision. You can see the bone over here. The ostectomy has been performed, and this is pre-op. This is the bone population a year later with a good alignment of the secondary palatine shelf. A 1-year follow-up with a nice reconstruction of his muscle, and this is a 2-year follow-up, and the patient is doing well in various respects. And you can see the quite impact on the difference on how they're able to integrate into society, being having to go around with a protuberant premaxilla that is projected. This is an oblique view as well with a 2-year follow-up. Jeremy, 5-year follow-up as well. No columella whatsoever. And this is him, on a 5-year and a 6-year follow-up with a nicely reconstructed cupid's bow and alignment, and a 7-year follow-up as well. The challenging cases actually that we have faced are many. This patient came in, as we had showed at the beginning of the presentation, completely collapsed secondary palatine shelf. We tried every single trick under the sun, basically, to expand him. He was a Venezuelan refugee who came all the way to Ecuador, and we tried to provide him. First, he was undernourished, and we built up his nutritional status. We did the pre-surgical orthopedics. We cannot get him to expand with all these maneuvers as well. And finally, we expanded his secondary palatine shelf using a 4-prong retractor, and that gave me access to the secondary, to the vomer bone that allowed the vomeral ostectomy to be done and the bilateral GPP. And this is him 3 years later after the lip and the palate and the alignment had all been performed, with a 6-year follow-up on this patient. We published this paper in CPCJ in 2021, I believe, or 2022. And from there on, we kept track of how many patients are requiring premaxillary setback with expansion. And it's close to around 18% of our patient population are needing this manual expansion as well, for either failure of PSIO, or they come in from remote areas and they're not yet able to undergo PSIO. And to try to repair a lip in front of this projected premaxilla is basically will result in disastrous outcomes as well. So this technique is now being employed in various parts of the world, including in the US, and it's allowing our surgeons to nicely align the GPP and the premaxilla with the secondary palatine shelves. The same thing, we expanded this with the 4-pronged retractor, and this is the nice alignment a year post-op. The other challenging case is when they come in with an intact palate, like in this patient whom we recently saw. We had to open up the palate and manually expand the secondary palatine shelf to be able to access the vomer bone. Did the Vomerine ostectomy, and then subsequently the GPP. And from there on, we were able to push the premaxilla backwards and did the primary lip repair. And this is the patient pre-op and immediately post-op, and within a 5-month follow-up. And this is her a day post-op and 5-month follow-up. This is the patient that I just discussed at the beginning of the lecture, when the surgeon did 3 attempts to repair the lip in front of the projected premaxilla. And unfortunately, it was completely locked, and she did not know her limits. And they kept blaming the mother for having fed the baby in the wrong way, and that's why the lip kept opening up. So the family was emotionally traumatized, not only by the baby, but also by the guilt feeling that they have done something wrong to her, their own child. The prolabial flap really had nothing. It was a total scar tissue, and I ended up having to use an eye knife to use as much of the left skin to reconstruct what we could produce into a prolabial flap. So what typically would have taken a 3-hour to do this 5-in-1 surgery took us 7 hours to be able to get to the outcomes that we ended up getting. This is the vomer bone. This is the ostectomy. We ended up manually expanding the secondary palatine shelf. And this is the patient 1 week post-op. Not the best outcome as I wanted, but probably much better than having end up basically with this kind of outcome. It's a nice aligned jaw and this is her 4-month post-op, quite a transformation as compared to having left her basically living like this for the rest of her life. Another patient basically who was operated on by another surgeon 4 times, and this was the outcome. She was called the monster. She had to drop out of school because people were making fun of her. She had no chance to integrate into the society. We did a type 5 cleft lip revision, premaxillary setback, and also manual expansion at the age of 17 to allow us to do the premaxillary setback. Since also the premaxilla was locked in front of a collapsed secondary palatine shelf. This is her two-year follow-up, a 4-year follow-up, and she had a baby, and the baby was born with a cleft lip, and we also provided the lip repair for her baby as well. We follow up our patients very closely, and our board member developed a nice nifty tool called My Health Pal that uses AI for wound assessment and wound healing and notifies the provider on daily basis on how the wound is healing, and it minimizes unnecessary visits to the emergency room, and at the same time it allows us to follow up the patient and advise them in the proper way on how if they need any proper care or not. I'll be happy to share the link with you guys if anybody is interested in this app. And from concept to creation, this has been a very challenging thing to try to teach people on how to do a premaxillary setback in the right way. This was the first model that we started working on. And this is the existing model that's now in creation, and hopefully we'll be releasing it for the first time in Cape Town, South Africa in November of this year. And the tissue also allows you to do a Vomerine ostectomy and the GPP, and also will be able to teach the people how to be able to do the surgery in the right way. We're setting up a lot of guidelines for certification because I don't want people running around the world doing these setbacks without proper certification and training, so to avoid any damage that might happen to the patient. The next meeting will be in the second regional Pan-African workshop in November, and I hope many of you will join us either in person or virtual. And the 8th International Cleft Workshop will be in Kuala Lumpur in the neck woods of Taiwan in October of next year. And hopefully many of you also will be joining us. And I'll finish my talk with what Marcus Tullius Cicero said 106 years BC. Not for ourselves alone are we born. So it is incumbent on us to be able to continue to share our knowledge and know-how and try to do the best for our patients without doing any harm to them, and trying to continue to improve our skills and never ever be confident that we've reached the peak, because we continue need to work on our skill set and to share our skill set with other people as well. And I'm open for any questions, PY.
Yeah. So, Professor, that was amazing, and congrats on your excellent results. Those were really beautiful. So at this time, I'd like to invite our panelists for some discussion. So the first panelist that I'd like to invite is Professor Feng Wen.
Thank you, Junior. Professor Hamdan. Congratulations. Those are great results, and I really appreciate your thoughtful approach to some very, very challenging problems. I think any of us who do a lot of global work encounter a lot of these patients who are suboptimal conditions and suboptimal access to PSIO. I have a couple of comments and questions. Now, you mentioned in the literature, it is somewhat divided in terms of where you place the ostectomy, anterior to the suture versus posterior. I've certainly found that depending on where you put it, yes, there's a concern for blood supply, but also its translation versus rotation. So if you put it anterior to the suture, on one hand, it's easier to get the posterior movement, but I feel that that's more of a rotation because the fulcrum is anterior. And I found that later on, when you follow these patients, then you have, when they have dental eruption, that the teeth are very retroclined. Now, a lot of what we do in cleft surgery is you basically solve one problem to create a new problem later on. I do agree with you that it's important to try to get the premaxilla closer into the dental arch to prevent that collapse of the palatine shells. So I guess my question for you is, what is your experience as these patients grow up, and though the premaxilla is better aligned within the palatine arch, with retroclined teeth, what is your experience in terms of getting improved occlusion when they get further and further out towards skeletal maturity?
Thank you for this very important question. Actually, two things. We notice first, as you know, if you use this maneuver to push the premaxilla backwards, you're causing retroversion actually of the teeth as well. So it's very crucial. We tell our assistant, when you're pushing it, you need to keep pushing it forward. I mean backwards, but to keep the teeth basically in the same alignment. And using this maneuver actually had saved us a lot of problems of the retrusion that had been encountered with other people. To the fact that you're closing that gap quite significantly, even if in our case we had around 18% of our premaxilla mobile laterally, none of them was mobile anterior posteriorly because of the Vomerine reossification. Basically, the trick basically it minimizes the extent of the alveolar bone grafting that you need to do at the age of 8 or 9, and it also allows the proper orthodontics basically that to do their magic trick when you're able to implement that. But you've realigned the jaws in a nice way rather than having to bring the whole thing backwards. And the fact that now we're able to expand the secondary palatine shelf and realign these things in place also has made the work for the orthodontist so much less as well. My concern basically is inversion of the secondary palatine shelf that has happened with NAM, with people who don't know how to do the NAM in the proper way, or the inversion of the premaxilla as well, which we have not really encountered in these cases.
Thank you.
Thank you, Professor Nguyen. Next, I'd like to invite Professor Bernard Tensipek.
Hello.
Hello.
Hello. Hi, sorry. Yes. Good evening.
Hi.
Thank you very much for your very enlightening lecture. I'm sure, I think the reason why they invited me because the Philippines is a recipient of a lot of mission work, and the NCF, our foundation, has been the last hope of these patients who have undergone problematic bilateral cleft lip repair. Actually, I have a lot of questions, so I hope you don't mind if we go through them. Is that all
Not
right?
at all.
Okay. All right. My
Yes.
first question is, what is your criteria for doing your premaxillary setback? Do you do it in all patients, or what in the anatomy or the measurements that you see that you say, oh, this patient will benefit from a setback, this one I can do without having to do a setback?
Anyone who cannot undergo PSIO,
Mhm.
starting from the first week, where the bone is still moldable, and who come in to us basically, and who need repair of the bilateral lip. If there are multiple factors. One, if the secondary palatine shelf are in any way, shape, or form collapsed, that will not allow the posterior mobilization of the premaxilla if you're able to repair a lip without a need for a setback.
All right. So
So
do you?
somebody who might not need, sorry to interrupt you. So somebody who you might be able to close the lip, and the lip repair should be able to push the premaxilla backwards. So if it's not projected much enough if it's the projection is under 5 millimeter, and the lip repair is able to move that premaxilla backwards so that it can marry the secondary palatine shelf. Usually, bilateral lip repair is done, and usually the closure itself works as a PSIO to keep the thing in place. But if you've got the secondary palatine shelf like this, and even if it's a 5 millimeter anterior projection and it's locked up, I would go ahead and do a premaxillary setback. Invariably, our patients who undergo these things are between 8 millimeter to 1 centimeter or more. And like with the patient Oliver, whom I described, was 3.5 centimeter anteriorly. And he came basically by the time we saw him, he was like almost 2 years old and completely ossified. And as you can tell, and as you know from NAM as well, if you're bypassed 4 to 5 month age in we're doing any pre-surgical orthopedics, this bone, no matter how much NAM or pre-surg PSIO you do, the bone is gonna stay.
Not gonna move.
It's not moving anywhere.
Yes.
And I
Is
agree,
there?
and I agree with you. I had mentioned that to you. I think I once mentioned to the group before you joined. I was invited as a speaker for the Filipino Society a couple of years ago, and they were discussing the situation as they have a lot of visiting groups operating primary lips and palates and leaving the kids with disastrous outcomes. And then many of you guys are seeing the thing. So I was discussing with them how they can discuss with the authorities the need to increase public awareness about this thing because it's costing people money, life, quality of life, integration, and somebody is paying the price, unfortunately, for that in so many ways.
Yes. Unfortunately, that I think that's a political issue that I don't think we can deal with
Yeah.
in this. But I have another question. When you remove the bone, do you also remove a part of the septal cartilage, or
No,
just keep it?
we don't touch the septal cartilage.
Mhm.
And I'm
In
willing to live with an angulated septal cartilage that eventually can be repaired later on,
Mhm.
but not to mess up with Mother Nature beyond the stuff that we're doing as well.
All right.
And every patient, as I mentioned, who undergoes Vomerine ostectomy with this technique, when they come back for the cleft palate, we're documenting the repopulation of the vomer bone as well.
All right. Sometimes the distance, the lateral distance between the premaxilla and the lateral segments are a bit off. Like sometimes you have a very wide lateral segments and your premaxilla will really be too small. Do you have to end up doing GPP on one side, or how do you deal with that?
Thank you for this question. Actually, I've taken care of several of these patients, and the premaxilla has been so traumatized either from the birth canal coming out or broken or fractured as well. And I've done GPP actually on both, even when I could not close the gap with the stitch on the other side. And surprisingly enough, when they come back for follow-up, basically the continuity is amazing. I'm sorry, I should have added these pictures to this thing, but I did leave it, a bit of a gap, but I would just wanted to hold it in place. And surprisingly enough, as the body has grown, the secondary palatine shelf compensated for that as well, and it was a nice alignment.
So, so for those cases with a very wide lateral segments, do you end up doing a more extensive dissection of the lateral segment mucosa to bring the tissues together, or just a
I just
minimal?
try to hold the premaxilla in the same latitude as the rest of the secondary palatine shelf, and again trying to minimize any additional trauma because these, as you imagine, the premaxillas with these that are microtic basically are quite susceptible to more damage as well.
All right. Thank you. Thank you very much for the information.
Thank you.
I really appreciate your technique. I think we can try. We'll be trying it in hope some of the cases that are being sent to us from other centers. Yeah.
And I'll be more than happy to share with there's a JCM, Journal of Clinical Medicine. We published a 17-page article. It's open source, and maybe I can attach the article here as well for you guys. But it's an open source, for accessibility as well. Or you can email me, and I'll be more than happy to send it to you as well.
Thank you very much.
Yeah.
Thank you very much.
Thank you, Bernie. Next, I'd like to invite our next panelist, Professor Freitas.
Thank you to Usama. Very nice lecture. We already had another session together, and you know that I have a totally different approach for bilateral cleft lip. I have a very conservative treatment. I do for all my patients lip adhesion, and I'm always afraid about three things: cosmetic, and of course, speech and maxillary growth. So when I saw papers with a long follow-up, like a Malik and others, and the instance of orthodontic surgery is over 75%. That when I saw our cases here, we have less than 35. So I'm always afraid about that, because when I saw setback of premaxilla, I'm really afraid about the first maxillary growth, and another that I'm going to ask you about necrosis. So I already saw some case of setback with necrosis around the world, not here because we do not do. But how do you think about the maxillary growth in the long follow-up? Because you just present for us 4 years, 5 years, not a long follow-up. But when I saw Mulliken, for example, he has one paper with a 92% of orthodontic surgery. It, to me, is too much. But I'd like to know about this, about the maxillary growth.
Yeah, and again, the paper that we submitted that was published, and the second one is now in being reviewed by CPCJ, shows that there is no difference in the facial growth between our patient population and the controls who were born with no cleft. The follow-up is up to 10 years in this patient population, and we're going to continue to follow them up, and we're going to go the assessment. My expectation, hopefully, is there probably will be minimal difference in the facial growth, and hopefully they will not need as much of orthodontic surgery as Mulliken's patients unfortunately had to undergo. If we're successful in providing them with this decent quality of life, the integration into the society, a 5-in-1 procedure, they are going to be able to go back to school and speak fine and integrate well, rather than having to continue back and forth with these limited procedure. And many of them come in from very remote areas that, you're going to do a lip adhesion on them and you're going to lose them to follow-up. In your case, I mean, you're in a superb center in Rio. It's a different situation from somebody coming in from 7, 8, 12, 16 hours away by bus, and not to mention, geographical insecurity situations. But I will continue to do these prospective studies. By the time we finish this multi-center study, hopefully we'll have around 80 to 90 patients, and we're going to continue to assess our patients as they continue to grow. And in the coming 5, 6 years, hopefully we'll be able to publish another paper on this issue.
Thank you. And
But our commitment is 100% dedicated to the betterment of our patients' quality of life. And we're going to be publishing the studies one way or the other, basically on what the outcomes were.
Perfect. And another question, and the last one, it's about your GPP. Do you have a control of X-ray about if growth and fusion of this bone, or just close the mucosa, or the bone is fused? I don't know. I didn't see any talk about.
Yeah, all our patients actually who were in the study underwent cephalometrics, and and the assessment basically of the facial growth was based on the cephalometric analysis as well. And as I mentioned to our colleague, and in these patients, around 18% of our GPP basically are mobile laterally, but not anteroposteriorly. And we have had zero loss of our premaxilla among all these cases that we have done. And my hope is with the narrower gap, they're going to require much less ABG grafting as compared to the wide gaps that you would have to do if they had to undergo just the regular techniques.
Okay. Okay, thank you, Usama. Congratulations.
There's the question, what is the technique algorithm to expand
Oh, wait,
contractures?
actually, Professor Hamdan, we'll go to the Q&A in a second. But
Okay.
first, I think Professor Lowe would also like to comment too.
Okay.
Yeah, Dr. Hampton, very nice to hear your talk. Wonderful result. Like to congratulate your technique. I would like to hear your more detail about the manual expansion. I saw some of your case, the lateral lateral segment is collapsed behind the premaxilla, and you said you do manual expansion. Is that the intraoperative technique, and how do you do that?
Yes, it is intraoperative technique, and as I mentioned, we published a paper on this thing as well as in the chapter book that I published a couple of years ago. You use a four-prong retractor to hook up the teeth under on the nasal side of the secondary palatine shelf, and you very carefully manually expand the secondary palatine shelf in a very controlled manner. If you're not careful, you're gonna rip through the whole mucoperiosteal flap actually with the four-pronged retractor teeth. And this manual expansion aid requires a lot of finger strength in the process to be able to do that. And even in the younger babies, the bone is so much solidified, basically. But with this maneuver, basically, you're able to expand it with two clicks wide enough to give you access to the vomer. If the vomer is completely collapsed, as I have shown you with the Mateus case, or if they're partially collapsed, but they still need further expansion so that the premaxilla can be positioned posteriorly and aligned nicely with the secondary palatine shelf. But without doing this manual expansion, there is no way on earth you're going to be able to get the lip to be repaired. It's going to continue to be locked, and the bone is not going anywhere. Then you're getting them into pre-surgical orthopedics at a much later age with all the stigmatization and the bullying and the dropping out of school and so on and so forth as well.
Okay, thank you. The second question actually is regarding you already mentioned regarding the ABG, alveolar bone grafting. You said you have not yet have the data to see how many of your case after this GPP, how many of the case that still require alveolar bone graft. Do you have now some preliminary data?
Not yet, but we're getting there. And I'm hoping basically that we should be able to generate a paper in the coming 2 to 3 years based on the growth of our patient and the proper follow-up that we have for them on the ground.
Okay. Thank you very much. Thank you.
Thank you.
Okay, thank you, Professor Lo. And now we'll go to our Q&A session. We have a very active audience today, and we have lots of questions. So
Yeah.
we will go through them one by one. And the first question is from Professor Steinberg. And the question is, do you have any experience doing this together with primary palatoplasty rather than chyloplasty?
I would not do this. Too many incisions. I was asked multiple times about this, and I say, don't mess up too much with Mother Nature. We're already doing significant amount of surgery for these patients to jeopardize the blood supply to these patients, and to jeopardize also the fact that we close the vomerine flaps in a meticulous way is what's really allowing all this vomer bone to regenerate. The fact that you measure exactly the distance of how much to excise has not really left us with any gap in our patient population, all the documented cases of the bone population. But to do this and to leave the stuff open, and it's too many potential unknowns and complications with the damages, and the risks by far outweigh the benefits from that. And I am really, I don't believe even in this combined procedure where they do the lip and the palate, even without the setback. I know some people are doing the lip and palate at the age of 7 or 8 months, and I've looked at these outcomes, and I'm not really much impressed with what I've seen.
Okay, and our next question is from Kabuyaya, and the question is, how do you stabilize the vomer bone after your osteotomy or setback?
With the 8-point fixation system, 4 sutures on the palatal side and 4 sutures on the buccal side. And again, I'll be more than happy to send a copy of that article to everybody as well.
Okay. And our next question is from Bona, and Bona has a question regarding the suture suspension. He said that they also add one more to the lower lateral cartilage with a slight overcorrection, and also they also do the multiformis cinch overcorrection, and he would like to ask you for your advice on that.
I'm sorry, can you repeat the question again?
So he said that he regarding the suture suspension, they add one more to the lower lateral cartilage with slight overcorrection, and he would like your opinion or your advice on that.
By the way, I'm putting in the chat group over here a copy of
Yes.
that article that I published on the
Okay.
JCM, and which includes both the technique for the setback as well as for the lip. Um, so we do my rhinoplasty technique is the following. I do a transcolumellar dissection between the skin and the lower lateral cartilage. It's a cartilage sparing technique. So I'm cutting the space between the skin and the lower lateral just to allow the domes to be mobilized immediately. The alar base flap incisions allow the rotation of the alar flaps medially. The alar base flap suspending sutures allow you to hold it in place. And then we put two double dome sutures, one double dome suture on the lower part of the dome and the second one on the upper part of the dome. And then you put the soft triangle suspending suture, which really has allowed us to give you this nice symmetry of the nostrils without having to do a Tajima incision, which I don't like to put an incision in that area. I don't do overcorrection because I believe, as you can see, from my technique, basically the nostrils are pretty symmetrical, and there's no incision at all in the nostril area, short of the areas that we have just, So my concern basically, Junior, is I know a lot of people like to do like 30% overcorrection of the nostril. What do you do with that? Basically, if the nostrils are stuck, and this is something that in our specialty we have not really been addressing. What is happening to the alar valve? What is happening to the patency of a flow through the nostrils that are constricted, and the quality of the life of our patients? You see them basically, especially in unilateral, one side is normal, the other side is 20-30% narrower. And we continue to do turbinate flaps and this flap and that flap. I have no problem narrowing a nostril postoperatively later on when we have enough tissue, but to widen a constricted nostril with alar, grafting and stuff like that, I mean, with the cartilaginous grafting is very inconvenient. So I try to avoid this overcorrection.
Okay, perfect. And next question is from JG. And I know you said that you mentioned about not touching the nasal septum during your operation, but do you experience buckling of the nasal septum during setback of the premaxilla? And how do you address that?
There's buckling in the thing because, again, we have not taken, the septum is like this, and you've taken out some excess tissue, so it's gonna buckle up. And whatever maneuver you're gonna do, whether it's a V-shaped incision or morcellization or whatever stuff, you're doing damage to the septum. I prefer to let Mother Nature take care of itself initially, and then at a later stage do the septoplasty without much affecting the growth centers in that crucial area.
And how long after do you do the septoplasty?
And when I'm doing the definitive rhinoplasty.
Okay. Okay.
Yeah.
And our next question is from Carlos Dorado. And the question is, one of the biggest problems in humanitarian program is the oral health. So he like to ask you, what do you do if they have infection and if the GPP got lost? How do you manage the mobile premaxilla?
Yeah, so we will not do any GPP, or we will not do any of these procedures if the oral teeth, and I 100% agree with the gentleman. I would not do any GPP if the poor oral hygiene is not there. And I'm 100% committed to oral health. As a result, in the Cartagena, our 7th international cleft workshop, we had a 2.5-hour session on oral health. And I will continue to lecture and talk to people about the need for maintaining proper oral health and working with the governments. And so it's so crucial for us to be able to educate our patient on this situation. And now we have very sophisticated postoperative discharge instructions for our patient to maintain that. And I tell them, if you come back to me with poor oral hygiene, I'm not going to be able to provide you with the right care and or even the proper surgery that they needed. But if there are poor oral teeth, basically the patient does not get the surgery.
Okay. And our
And
next,
what I tell them basically is you're really getting, you're getting like a Lamborghini kind of surgery done, and you're shooting the tires with gun and with bullets. Basically, you have, you're going on flat tires. What's the sense in doing this amazing work when you have not taken care of your oral health and oral hygiene?
okay. And our next question is from Professor Honda, and the question is, do you need orthodontic fixation? For example, even like in adolescent patients, would you ever need orthodontic fixation?
Basically, we send all our patients, our teams on the ground provide oral health as well as orthodontic and pediatric dental care as needed. So all these patients, whoever need the orthodontic work, will get it accordingly.
Okay. And our next question is from Ivy. And Ivy's question is there a maximum length of bone that can be removed during the ostectomy?
I mean, this patient, Oliver, 3.5 centimeters. And
Okay.
I documented this actually, and I showed you the slide with the CAT scan as well, and with the amount of bone that we've taken out. And if you remember, basically, the post-operatively, the patient has done exceptionally well as well with the facial growth, and and at least and for now, and with the way he looks.
Okay. And then the second part of the question is, how do you do post-op scar treatment and taping?
So we have basically all our patients, all our sutures are dissolvable. Don't need to bring the patient back. We use 5O and 6O fast absorbing plain gut and 6O monocle. The 6O monocle, in case we use it, our surgeons on the ground basically, or us, will take them out. Dermabond is applied actually on all the patients to allow the protection for a week. And then from there on, within a month, if there's any minimal scar hypertrophy, we have the scar gel, and we discuss with the patient basically how to do the massages 5 times a day, each time for 2 minutes in a very gentle way. Sunblocks, sun protection, everything is all actually in our discharge instruction sheets that actually we're publishing a paper on right now to share with everybody. And we got some for lips, some for palates, some for the premaxillary setback, oral hygiene, feeding, diet, all the stuff with all the illustrations and the pictorials as well.
And how long do you apply the scar gels for?
Usually for a month or so, but we continue with the massages with a bit of lotion to up to 6 months.
Okay.
And as
And
long as you see any kind of minimal hypertrophy, the
yeah,
massages need to continue to be applied.
okay. And our last question is from Dr. Davila, and the question is, how do you treat adult patient with protruded premaxilla? And if it's with the same technique, how do you stabilize the premaxilla with permanent teeth?
The same exactly. I showed you the patient Jocelyn who needed a type 5 cleft lip revision, and in a way actually let me see if I can share the screen. Uh, so this is Jocelyn, and she had 4 procedures before we saw her because the premaxilla was locked anteriorly in front of a secondary palatine shelf. And basically, we did the Vomerine ostectomy and the manual expansion at the age of 17, believe it or not, of the secondary palatine shelf to be able to push the premaxilla backwards. And this is the outcome. Not as perfect as I'd like to, but clearly, quite a difference, from where she started with this kind of an outcome in a full lip. And we did the same 8-point fixation system as well.
Okay.
Four on the palatal side and 4 on the buccal side. And this is all in the article I just shared with you as well.
Yeah. Okay, thank you so much. And I think that's the last question for the Q&A session. So, PY?
Thank you. Thank you, Junior. Professor Hammond, I have another questions for you is that I'm really appreciate your new technique to reduce the vomer length and you can easier to set back of the premaxilla bone tissues. I just wondering because we add additional scar and incisions over the vomer base. is that you will encounter some difficulty or problem when you perform the further palatoplasty, is that the tissue is not easy to approach cemented, or that will make some problem for you for the next palatoplasty procedure. Yes.
None of our surgeons basically has encountered any problem with the palatoplasty in our patients who underwent Vomerine ostectomy. And as I mentioned, basically because of the conjoined double Y incision, you're minimizing any shearing effect or tearing of these flaps. We spend a lot of time putting these flaps nicely together, and our palates, basically our patients who underwent the palatoplasty have done very well. Few required buccal flaps because of some of the flaps basically ended up with a small palatal fistula that was repaired successfully with the buccal flap.
Yeah, thank you so much. And finally, I would like to invite Professor Hamdan. Could you like to advertise once again for your work shop in South Africa in this November to all our participants in this panel as well?
Thank you so much, certainly, and thank you so much for the giving me the floor to be able to share this. So we will be doing our second regional Pan-African Comprehensive Cleft Care Workshop in affiliation partnership with the University of Cape Town in the lovely city of Cape Town, and at the DoubleTree Hotel. We have accommodation for up to 250 participants, and we have 50 international and African speakers. We are running 12 simulation labs and specialty workshops: unilateral lip, bilateral lip, cleft palate, and buccal flaps for posterior palatal fistula, premaxillary setback, and facial nerve blocks, along with feeding, psychosocial, speech, dental, NAM, and Pedro Santiago actually is giving a 2-day course on our 8th International CCW will be in Kuala Lumpur, and we're expecting over 90 international and regional speakers to join us. 3.5 days, 23 specialty workshops and simulation labs, and with many new simulation models as well being released. And I'm quite excited actually about the addition of genetics. We also will have poster session and an abstract session for the younger generation to be able to present their cases as well.
Thank you, Professor Usama, for your long-term contribute to this cleft care. Finally, I really want to invite all our participants, and we can show you a smile, and we need a group photo. Today, we still have a lot of very experienced all the professors in this ICC webinar too. I believe we all learn quite a lot, and we still have a lot of questions still unresolved yet. For example, like Professor Rinaldo has mentioned, the long-term follow-up of maxillary growth in the future, how the maxillary develop for the adolescent stage. Yeah, so Professor Usama,
I just sent you my email in case anybody would like to reach out with any questions, and I'll be more than happy to share many of the articles that we have published actually on the subject as well, and we're going to continue to publish our work. In Cape Town, we will be distributing close to 150 or 200 copies of the new special issue of the Annals of Plastic Surgery. It's 19 chapters actually on cleft care as well, that I'm very happy to be able to share with everybody around.
Thank you so much. And by the way, I have to appreciate the one of my good friend, Professor Fong. Yeah, Professor Fong annually to visit his hometown in Hanoi, Vietnam, to bring a whole team from States to give the cleft mission freely, and not only for the surgery as well as the symposium to educate all the young generation in Hanoi. Yeah, I'm so sorry not meet you this year in Hanoi, Professor Fong. See you next time.
Thank you, PY. Yes, I'm sure we'll see each other soon. And thank you, Professor Hamdan.
Yeah,
thank you. Yeah. And actually, our dear friend Chris Runyon actually is one of our speakers and a dear friend. I think he's part of your team as well.
That's right. We're just talking about your symposium in Malaysia. I just saw Chris 3 days ago. So
Great.
congratulations.
Yeah, and finally, my good friend Bernie. Bernie always dedicate himself in the local Philippines flag missions. Philippines is quite a large island compared to Taiwan, and still has a growing number of the new cases of craniofacial deformity yet. So thank you, Bernie. Sometimes give me the opportunity to go visit you and learn from you as well. All right, I have to introduce our next speaker. That is the 1 week later. Professor Murad will be invited to ICC to give the topic, the microtia, which stage is better. So looking forward to you come again to join the meeting as well. So may I count to 3 and please show me your beautiful big smile and we can make a group photo. 1, 2, cheers. Thank you guys so
Thank you.
much. 5 hours later, the champion of the 2026 World Cup, the game is ready to start.
Thank you.
Fight for your team, please. And looking forward to your participant 1 week later.
Thank you
Have
so
a
much for
good
the
day
kind
and have a
words.
good night.
Thank
Thank
you.
you.
Thank you.
Take care.
Bye-bye.
Thank you. Bye-bye.
Good night.
Bye-bye.